Welcome to my presentation on pulmonary function testing and COVID-19 long-term implications. My name is Terrence Shenfield and I am the co-owner of A&T Respiratory Lectures. You can imagine that a patient who suffers from COVID-19 walks away with some major pulmonary issues. For example, in this image, this is a CAT scan of the chest showing interstitial changes with ground glass opacities. This occurs in approximately 75% of all patients hospitalized for COVID-19. The long-term implications of some kind of pulmonary function disorder is really high. And most evidence has shown that it's really not to do with flow limitation, but more with your DLCO. And this is what this presentation is more about. It's more about how the DLCO is impacted through COVID-19 and the resolution of that process. Today's objectives, we will be talking about certain things. We're going to be talking about a basic background of COVID-19, which I'm sure you all know. I'm going to talk generally a little bit about pulmonary function tests, but then I'm going to narrow it down to the diffusion test, or the DLCO, because that's the test that's mostly impacted through COVID. I'm going to talk about the ramifications of post-COVID PFTs. I'm going to talk about long-term consequences, and I'm going to talk about what the long-term possibilities of improvement are with this disorder. Let me give you a little background of what's going on. We all know that COVID-19 pandemic had a significant impact on the health of many people across this nation and the world. Regarding morbidity and mortality, this represented a major challenge to healthcare systems throughout the world, and many people have died. Many people have recovered from COVID, but some of them have long-term symptoms. I am sure you heard the word of long COVID, where people are suffering from dyspnea, fatigue, exercise fatigue, headaches, arrhythmias, and so on and so on. But this particular lecture, we're going to talk about pulmonary impairment and lung function. So patients who have recovered from COVID, and I showed you the CAT scan on the previous slide, they have long-term implications with their pulmonary function test. Pulmonary function testing has proven to be quite beneficial to show the progress of improvement with these patients. A lot of times patients who had COVID and recovered, especially those who were hospitalized in mechanical ventilation, they have deficits in their pulmonary function based upon their DLCO values. And I'll get a little bit more into DLCO in the next slide. Let me give you a little background before we go much further in this presentation. We are talking about patients who recovered from COVID-19. We are talking about pulmonary function deficits that occur as a result of COVID-19, especially those who are mechanically ventilated. And of all the pulmonary function testing that is done, the one that is mostly severely impacted is what is known as the lung diffusion test, or commonly called DLCO. I'm not here to teach you how to do this test in the pulmonary function lab, because I'm sure a lot of you know exactly what to do. But here is a quick little background on how it works. The whole purpose of a lung diffusion test, the DLCO test, is to determine how oxygen is uptaked into the bloodstream through the pulmonary capillary membrane. And how it is uptaked is basically determined by this test. So what happens is this test is normally done in the pulmonary function lab, and the patient is told to inhale a small amount of carbon monoxide. And when they inhale this carbon monoxide, they hold it in for approximately 10 seconds, and then you exhale. The device, the pulmonary function device, will actually measure. They know how much carbon monoxide is when you start, and then when you inhale it, a lot of that carbon monoxide is diffused into the bloodstream, and then when you exhale, whatever the difference is the result of your test. And what happens is this test is really, really good to determine if you have some kind of diffusing deficit with your lungs. So when you breathe in oxygen, and if you have a diffusing deficit and you can't really, the oxygen you breathe in doesn't go into your bloodstream, I'm sure you're going to have some problems. So this is the biggest problem with COVID-19 and pulmonary function tests, because there seems to be some long-term consequences with this particular test. And I'm going to get more into it and go into the studies with it. I just wanted to give you some values. A normal DLCO is anywhere from 75 to 140% of predicted value. A mildly reduced DLCO is anywhere from 60 to 75% or within lower limits of normal. And a severely reduced DLCO is less than 40% of predicted. Now that you're armed with some values, you know what normal is, you know what mildly reduced is, and you know what severely reduced is. You'll have a better understanding as I show you some of the studies showing the impact of COVID-19 on this particular test. I wanted to highlight just how important the DLCO test is in pulmonary function laboratory. For example, it's a great tool to differentiate between asthma and emphysema or COPD. The American Thoracic Society and the European Respiratory Journal came together and created this flowchart. And basically, you could really determine whether someone has normal lung function, or if they have a restrictive disorder, or if they have an obstructive disorder, or if they have a mixed defect. Then you could further differentiate based upon the DLCO results, whether it's a pulmonary vascular disorder, whether it's a pulmonary embolism, whether it's pulmonary hypertension, whether it's interstitial lung disease. So you could really drill down to exactly what kind of lung deficit is going on. So I just wanted to highlight how important this test is as a differential diagnosis for lung disorders. When you think about the impact of COVID-19 on pulmonary function, at the time of the pandemic, most pulmonary function laboratories closed. I mean, you wouldn't want someone breathing into a machine with a respiratory condition that you didn't know nothing about. And I remember at my hospital, we did actually close our pulmonary function lab, which is kind of sad. But the fact is, there was approximately 120 million people who were impacted by COVID worldwide, and many of the pulmonary function laboratories closed because they were concerned about, spreading the disease. And one of the problems was that there's not many good studies coming out as a result of that. So one of the first studies ever coming out was in 2020 by Mo. And I'm going to get a little bit more detail about exactly how this study came about and what their findings were regarding to pulmonary function impact. One of the first studies to be conducted with discharged patients with pulmonary function testing was actually done in China in 2020. And what they looked at 110 patients where the average age was around 49 years of age, plus or minus 14. 50% were women, 50% were men. And upon discharge, when they looked at pulmonary function testing, of that, around 24 of them had mild symptoms, about 67 of them had moderate symptoms, and approximately 19 of them had severe disease. So when you really look at it, most of them were discharged with some form of moderate pulmonary function disorder. And what they've noticed that with these patients who were discharged and they did the pulmonary function test, they noticed that the biggest impacted pulmonary function test was the DLCO, a diffusion capacity test. That was the test that was mostly severely impacted by COVID. Another thing they noticed that there was a restrictive ventilatory pattern with a reduction in total lung capacity and residual volumes. That almost indicates there's some kind of interstitial-based process going on. So from the findings, DLCO was mostly impacted, and then they had some kind of interstitial-based process going on with reduced lung capacity and reduced residual volumes. So this was the first study to come out, and some of the findings they found from that. And there are other studies, but the focus here is the DLCO. Another study I want to bring to your attention was a study done by Friedrich Mason. And this study was published in the European Respiratory Journal in 2020. Again, it was a small study because, remember, they were closing pulmonary function labs at this time. But during this study, they looked at 45 patients who were post-discharge from COVID. The average age was 54 years of age, plus or minus 8, approximately 44% women, which means 56% men. And all of them, they were healthy prior to this study. So on discharge, about 12 of them had mild symptoms, about 17 of them had moderate symptoms, and approximately 16 had severe symptoms. Approximately 80% of all the patients, or 81% of all the patients on discharge, showed some kind of pulmonary disorder, and the most common thing they found was reduced total lung capacity and reduced DLCO. They also noticed that there was extensive injury to the alveolar epithelial cells and endothelial cells. And also they noticed there was alveolar remodeling leading to lung fibrosis. So you can see this is a restrictive disorder. It has a long-term impact on lung function. And these are pretty severe studies being shown with patients who are post-COVID. So from what we learned so far about patients who had COVID and were discharged home, there is definitely some kind of impairment to pulmonary function. Now we got to remember that COVID was first described in November of 2019. And as a result of that, many pulmonary function laboratories closed down, so we didn't get a lot of data. But after the fact, we started doing some studies. We have a lot of observational studies, and 42% of the patients who were discharged post-COVID had some kind of pulmonary function impairment. Approximately 27% of them show a restrictive pattern on this spirometry, and about 11% of them showed reduced total lung capacity via body box. Most importantly, it seems like the implications are that approximately 31% showed a reduction in DLCO, which seems to have a long-term impact on these patients. Spirometry values return to normal, but not the DLCO. And that's what I wanted to get into. I wanted to show you some more studies that point to this kind of impairment, and something as, respiratory therapists and pulmonary function technologists that we should be aware of, especially patients who have COVID. And we might know some people who have COVID, and we want to sort of give them the best advice we can. I want to give you this slide because it shows you that some of the early studies that were done on pulmonary function testing with post-COVID patients, most of them were done in China, and obviously it originated in China. And what they have found between all these studies, and I know I just explained this study by Mo from April 2020, but I didn't tell you about some other studies that were out there. Most of the studies measured spirometry, diffusing capacity, 6-mile walks, that was the common body box testing. And the common findings amongst all of these studies was that most of the patients had a reduction in their DLCO post-COVID, and a lot of them showed some form of restrictive disorder. So we could surmise that patients who had COVID, who got discharged from the hospital, had some kind of pulmonary insult to their lungs, mostly manifested by a restrictive disorder as well as a DLCO. I'm going to get a little bit more into the DLCO in a couple of slides after this, but I also wanted to tell you there is some good news. So the good news I'm going to present on the next slide, but I just wanted you to know that this presentation was based on a few different studies that I found out there. And most of them came from China, and most of the pulmonary function labs were closed at this time. Well, it's not all bad news. I just want to give you some good news. A study from 2022, basically it was a prospective observational study carried out by Fortini and Alberto. And they did a 1-year evolution of DLCO changes and respiratory changes in patients who were post-COVID. So what they did is they followed up some patients for a whole year, and they were looking at them who came out of the non-ICU who had pulmonary insult. Basically, 30% of them, 37% of them showed a decreased diffusing capacity and after 3 to 6 months after discharge, and they were evaluating the DLCO changes for a 1-year period. So basically they were discharged and then they were following up to see if there was any changes in the DLCO. And the good news was that the DLCO actually normalized within 1 year after hospitalization with COVID. There were also other patients who had some kind of respiratory changes that persisted who required follow-up. But the good news is that most of them, after 1 year of after post-discharge, had an improvement in their DLCO, almost back to normal values. So I think this is good news. And now I'm going to get a little bit into the pathophysiology of DLCO and how COVID impacted it. So you may ask, why is the DLCO test the test that is markedly reduced in post-COVID patients? Why is that particular system being most recognized as the insult that is most commonly found in pulmonary function tests, especially for patients who are post-COVID? And there's a lot of evidence showing that the DLCO is markedly reduced with patients who had severe disease. So the sicker a patient is, the more likelihood that the DLCO is going to be impacted by that. Typically, when you take an x-ray of these patients, they have this ground glass opacities, and you might recognize the word ground glass opacities because that's what happens with ARDS patients, and that is a restrictive disorder, and that creates all kind of fibrotic changes. Some of the pathophysiology, without getting into too much detail, there's a lot of local dysregulation involving the endothelial and epithelial cells. This is presented as injury to those cells. Also, there's been various degrees of thromboembolisms and also endothelial dysfunction in these patients. They believe that the pathophysiologic responses of COVID, and this is the reason why these patients end up getting restrictive disorders as well as a reduction in DLCO. They also have noticed that there's been significant cardiopulmonary circulatory pathophysiology involved with this too. So they believe this is the root cause of the DLCO abnormalities done during the test, and they think there's a strong evidence of fibrosis and progressive interstitial disease. So that is the reason why the DLCO seems to be mostly impacted with COVID patients. So another interesting fact is that COVID-19 patients who had some kind of pulmonary insult result in a restrictive lung pattern. And you want to know what the definition of a restrictive lung pattern, that would be a decreased total lung capacity with a preserved FEV1 over FVC ratio that is greater than 70%. That is the hallmark definition of a restrictive lung disorder. And the main pathological reason behind that is because you have inflammation of the airway. You have inflammation of the pulmonary parenchyma, and you have a lot of deposition of collagen in the interstitium. This results in a restrictive disorder, and also this results in pulmonary fibrosis. So that is the main reason why you have some form of restrictive lung disorder with certain patients who recover from COVID. So what are the long-term consequences of patients who had COVID-19? And as mentioned earlier, a lot of the pulmonary function laboratories were closed during this pandemic. Remember, this is relatively new. It came out in 2019, and really the world was shocked by it. Most prospective multi-center observational data demonstrated some form of pulmonary function impairment, as mentioned earlier, decreased DLCOs and also restrictive pattern. Interstitial lung disease is actually known to be part of the cause of the restrictive disorder, and it has very similar pattern as ARDS. So 60% of all patients who had severe COVID-19 actually had lung tissue that looked like post-ARDS patients. So yes, pulmonary rehab can be beneficial to a select group of those who are severely impacted. More research needs to be done on this, because this is relatively new and we don't have like long-term studies showing the pulmonary insult that occurs as a result of getting COVID. But, pulmonary rehab is definitely beneficial especially for those who show a restrictive pattern as well as decreased DLCO. So yes, it's a good thing. So we all know that post-COVID patients have some kind of pulmonary insult. And back when it first started, back in 2019, many pulmonary function laboratories were closed because we didn't know anything about it. But after time, we started doing some PFTs on these patients, and we discovered that patients who had COVID-19, especially if they had some kind of severe pulmonary infection, had some form of interstitial disease process that was more restrictive than obstructive. They had a decrease in DLCO, they had a restrictive disorder. The radiographic findings showed diffuse airspace interstitial-based processing, very similar to ARDS. Also, there was a big inflammatory process with COVID, and that led to impacted gas exchange, especially described by the DLCO test. There was really little damage to the muscle or muscle deconditioning unless they were intubated and put on mechanical ventilation, and as a result of that, they had muscle wasting. But on the most part, there was no kind of damage to the muscle tissue itself. There was some atrophy, but that atrophy was not related to COVID. It was more related to not using it. Most patients did recover within a year to almost normal function, but there are some outliers out there. Long-term consequences of COVID infection will be manifested in time. In other words, we don't have all the answers right now, but in time, when we follow up on these patients, we're going to learn more. But the takeaway is that you really need to know that this is a process that impacts the interstitium. There's a restrictive disorder, there's fibrotic tissue, there's a decrease in DLCO, and most of these patients need more time to recover, and we should follow them up over time and see how they turn out. In summary, early findings from these patients who had severe post-COVID infection shows that they have an impaired diffusing capacity with a restrictive pattern associated with interstitial changes, most likely fibrosis. This manifests itself with long-term dyspnea complaints from patients. So most of the patients complain of shortness of breath. In some cases, a lot of these patients have developed into pulmonary fibrosis, which there is some new research being done on antifibrotic therapy, but this research is being conducted as we talk and as this presentation is being mentioned. So I didn't really want to get much into this portion of the presentation. In most cases, patients are resolved within 1 year, but you do have some outliers, and these outliers can mostly benefit from some kind of pulmonary rehab program, and maybe that antifibrotic therapy, maybe the research coming out of that will demonstrate some effective medications that can help these patients. So I want to thank you for joining my presentation. I know we could have covered more into this, but there's new research being carried out now. And my next slide will be showing you some of the references in case you want to read more about it. Again, I want to thank you guys for joining me during this presentation. I hope you enjoyed it. I hope you learned a little bit more about COVID-19, especially if you're a pulmonary function technologist. You might want to know why are they doing these pulmonary function tests, or maybe you have a family member who's showing long-term shortness of breath. You could sort of learn more about exactly what the disease process is doing. And I want to thank you all, and I hope you have a great day.